not against screening. It's just that there is wise use of screening, and then there is overscreening. Let me give you some examples. The easiest one is in cervical cancer. There are about 4,000 women who are going to die from cervical cancer this year, and this study has been done time and time again. 95% of those women got no screening for cervical cancer within the 10 years of their diagnosis of cervical cancer. Most of them had never gotten cervical cancer screening at all. But there's a host of women in the United States, the majority of women in the United States, who are getting cervical cancer every year, cervical cancer screening every year. There is not a single organization, professional organization in the United States that recommends cervical cancer screening every year. Some tests you should get every 3 years if you choose to get them, and other tests you should get every 5 years. Okay, I've just told you that the majority of women in the United States who are adults are getting regular screening too often, and yet 4,000 women die every year and they never get screened. That's an example of overscreening in our society at large, leading to underscreening in the poor women who die from cervical cancer. In the issue of prostate cancer screening, we don't have good studies to tell us that prostate cancer screening definitively saves lives. All the major organizations in the United States, Canada, and Europe don't say men should be screened for prostate cancer. They say men should be informed of the potential risks and the potential benefits associated with prostate cancer screening, and then men should be encouraged to make a choice for themselves. I hear a lot of folks encouraging men to get screened for prostate cancer and not respecting a man's right to make that decision for himself. I hear a lot of folks promising that prostate cancer screening definitely saves lives when the National Cancer Institute says it's one of the most important questions in American medicine today. These are some of my issues.
Is the problem incentives, Otis? Is it that we're paying more for and incenting more screens, and we should be investing more in healthier behaviors? Is that at the bottom of what we're? That's
part of it. You know, it's hard to make a living off of prevention unless you're selling vitamins that don't work, and that's a real problem to begin with.
Yeah.
The other issue is, ever since we were all at our mother's knee, we were told the way to deal with cancer is to find it early and cut it out. And that was a fine message in the 1920s, perhaps into the 1950s and 60s. But the one thing that has happened in this medical revolution that we have is our screening tests are getting better and better, and we're starting to be able to identify a lot more cancer than we used to be able to identify. And we've not been able to reconcile this following fact. There are some cancers that God never intended for them to grow and kill. Yes, I can find a prostate cancer in a man, but many of those prostate cancers we now know are never destined to harm that man. And the greatest harm I can do is tell him he has prostate cancer and then go cure him. And the concept that there is a type of cancer that doesn't need to be cured is very hard for people to accept. You know, one of the things we should do more is define the molecular tests that are better going to be able to identify the cancers that need to be treated and the cancers that need to be watched. By the way, this over-treatment, this type of cancer that doesn't need to be treated, it exists in prostate cancer, it exists in breast cancer, it exists in thyroid cancer. Now, I'm not saying if you have a breast cancer, don't get it treated. I'm saying that the future of medicine is going to lead us to, Mrs. Smith, you have a breast cancer, but it needs to be watched. Mrs. Jones, you have a breast cancer that needs to be treated. That's the future. And we need to realize and invest in doing the research to get to that future.
Does the GRAIL test? I mean, these liquid biopsy tests that are emerging from Illumina and others, where they're looking at creating probabilistic models around based on what they see at a molecular level. Is that the kind of promise that you're hoping to see delivered from a sort of basically what you're saying: screen, test, treat, not treat. It's that kind of a if then.
Yeah, well, this is where I have to tell you I'm a consultant to GRAIL as they're trying to develop their tests. There are a number of these blood tests, we call them MCEDs or multi-cancer early detection tests, that are being developed right now. And these tests may have a number of different uses in the future. We're not exactly ready to say what all of those uses could be. Some of them are going to be useful to assess people after treatment to make sure they have not relapsed. Some of them may be used in addition to normal screening